Hello, I'm Dr. Mubin Syed, your Desidoc. Welcome to our program today in honor of South Asian Heritage Month. Today in our expert spotlight, I'll be talking to Dr. Alka Kanaya, a medical researcher focusing on type 2 diabetes, obesity, and cardiovascular disease, and is the principal investigator of the monumental MASALA study, which stands for Mediators of Atherosclerosis in South Asians Living in America. Dr. Kanaya's research also focuses on metabolic syndrome, which is a cluster of risk factors for heart disease, which is diagnosed as having excess fat around the abdomen, measured by a waist circumference of 102 centimeters in men and 88 centimeters in women, or a waist to hip ratio of 0.9 in men and 0.85 in women. BMI of 85, high triglyceride, BMI over 25, high triglycerides, low HDL, high blood pressure, or using medicine to lower blood pressure, high fasting glucose, and insulin resistance. Interestingly, South Asians can develop metabolic syndrome at BMIs of 23, greater than 23, as well as waist circumferences of greater than 90 centimeters in men and 80 centimeters in women. Dr. Kanaya has published 234 scientific articles and has been cited well over 16,000 times. Dr. Kanaya has received additional funding for her work related to the MASALA study, specifically in charting the natural history of diabetes and atherosclerosis in South Asians while trying to identify new risk factors, as well as a translational study using restorative yoga to combat metabolic disease. Welcome, Dr. Kanaya, and we're really honored to have you speak with us today.
Thank you, Mubin. It's my pleasure to be here. Do you hear that? There's a distortion in the audio.
Yeah, I do hear that a little bit. Is that going to be an issue a little bit?
Yeah, it seems like it's just connection right now. That everything else seems okay.
Is it coming from me?
I think so. Yeah. I think it's your speaker. Maybe it's not well plugged in or something.
I think it's the connection at the IR, Dr. Syed. It's usually a poor connection there. Maybe move.
I can move to a different spot. Would that work?
We could try that.
Okay, let me do that. Is it any better?
Get to a still point, and then we could see. It's
okay.
Well,
okay, how about this? Is this any better?
Actually, it's still the same. If not a little bit worse there for some reason. I don't know why.
Okay. Let me go to a different office.
Do you have a hotspot on your phone?
That actually may work best.
How about here? Is this any better?
No.
Okay. The only thing I can say, I'm happy to use my phone. I just don't know how to do it. I'll go back to my office.
Yes. Do you have an iPhone or a hotspot on your phone, on your smartphone?
Yeah. So I can just see. I have a Android.
Yeah. So turn on your hotspot under settings, and then
okay, that's what
and then on your computer, instead
settings.
of connect to Wi-Fi, you should connect to your hotspot instead of your local Wi-Fi. Yeah.
Okay, so here I'm under Wi-Fi, and I go to mobile hotspot. Okay.
Yeah.
And turn on mobile hotspot. Okay. Okay, I have to do data. Turn off data saver. Okay, so I got to turn off data saver first. Okay, come on.
Thanks for your patience, Dr. Kanaya. Sorry about it.
That's all right.
Okay, so trying to go to mobile hotspot here. Okay, so I'm going to, I am in mobile hotspot, but I can't actually turn it on. It's not letting me
Okay.
do that.
It may be best to just join from your phone, Dr. Syed, if that's okay.
Okay, that's a good idea. I can just do it from my phone. All right.
Much better.
Okay, good. Okay, excellent.
And I don't think you need to go through all of the criteria for the metabolic syndrome, honestly,
Yeah, I agree
because
with you.
they're very controversial, and there's different cut points based on different societies and all.
Yeah. So I'll leave that out. Maybe we can just start it over, and I agree with you.
Okay.
It seemed a little bit too tedious as I was reading it also. Okay. So we'll be starting here. Hello, I'm Dr. Mubin Syed, your Desidoc. Welcome to our program today in honor of South Asian Heritage Month. In our expert spotlight, I'll be talking with Dr. Alka Kanaya, a medical researcher focusing on type 2 diabetes, obesity, and cardiovascular disease in South Asians, and is a principal investigator of the monumental MASALA study, which stands for Mediators of Atherosclerosis in South Asians Living in America. Dr. Kanaya's research also focuses on metabolic syndrome, and she's published over 234 scientific articles and has been cited well over 16,000 times. Dr. Kanaya has received additional funding to her work related to the MASALA study, and specifically in charting the natural history of diabetes and atherosclerosis in South Asians while trying to identify new risk factors, as well as a translational study using restorative yoga to combat metabolic disease. Welcome, Dr. Kanaya. We're really honored to have you speak with us today.
Thanks. My pleasure to be here.
Let me start by asking you, what led you to start the MASALA study?
Well, being of South Asian origin myself and having seen diabetes and heart disease affect so many family members and community members as I was growing up, both here and in India, seeing how prevalent these problems were and just kind of taking it for granted that this just happens. It's just a problem that many of our community members face, that just hit me as something that is worth really digging into. So in residency and in fellowship, I really started to explore, like, what is known about this? Is this mostly a genetic problem? And turns out not much was known. And so that's what kind of opened the door to really looking at this in a thoughtful, kind of prospective way to be able to explore multi-levels of possible risk factors.
Yeah, that's very interesting. So it's really your personal experience with the community, the South Asian community, that kind of led you to see that something was going on.
Yeah, at home, and as well as, people around me in my community, as well as, my own patients that I was taking care of as a intern and a resident.
Yeah. And then, in your opinion, what have been some of the key findings from the study, the MASALA study?
Yeah, well, I think I'd like to put this in different baskets because we've published almost 100 papers now from the study. So there's a lot of findings, and I could say several of them are key.
Right,
but,
I'm sure you could talk for an hour.
at least. So I'll try not to be too tedious, but the key findings are, yes, we definitely confirm that South Asians have much higher rates of diabetes and other abnormalities with some lipid fractions, as well as some areas of fat deposition in their body compared to other ethnic groups. So one of the key things about MASALA, which I think makes it a really relevant and important study, is that we partnered with another ongoing study in the US that has 4 different race ethnic groups to really compare South Asians to whites, Blacks, Latinos, and Chinese Americans. And so that it's not a freestanding study. And so we use the same measures, the same, different types of research tests, as well as measurements as was ongoing in the multi-ethnic study of atherosclerosis. So this partnership has really made, our study be more relevant in that we can say that South Asians look worse on some parameters, they may look a little better on some parameters, and following people over time will really help us investigate what the primary causes of heart disease are, because we're going to follow people to see who develops heart disease. So in terms of other key findings, is we found that diabetes is very prevalent, 6 times the rate that you see in whites, and even twice the rate that you see in other, minority groups like African American, Latinos. And why is this? It turns out it's not only insulin resistance, which has been, purported as like the big reason that with metabolic syndrome, having more fat around the belly, that this creates more insulin resistance, the message of insulin, the hormone required to metabolize all, glucose and sugar in the body, isn't getting heard by the tissues. Insulin resistance is definitely a problem, but it turns out that a bigger problem is insulin deficiency. And so we've seen that even in the people who are not yet diabetic in our MASALA studies, when we measure how much insulin there is circulating, it's actually very low, much lower than what we see in the MESA groups. And so this brings up a lot of interesting, ideas and hypotheses that we still need to test to say, well, are we just born as South Asians with less, insulin, or is this something that we lose early on in life? And that's why we have this accelerated reason for developing diabetes. So the diabetes findings are one whole set of findings. Another whole set is coronary artery calcium. So we've done CT scans of the heart in our participants twice now, once at baseline and then again 5 years later, to look at calcified blood vessels. And this tells us that there is atherosclerosis, or hardening of the arteries, already happening. It's a non-invasive test. You don't need dye, you don't need catheters, and we can do it in healthy people without symptoms. And what we found is that there is a lot of atherosclerosis, especially in the men in MASALA, that the amount of atherosclerosis, and again, these people are asymptomatic. They didn't come to us to be in our study because they were having chest pain or they already had heart attacks. We actually excluded people who had already had any kind of problems with their heart or arteries from being in the study. So it's a healthy cohort without heart disease already. And we found that they had a lot of calcification in the coronary arteries, but not more than the whites in MESA. So again, we're comparing to the 4 groups in MESA. And we found that there was a lot, but not more than what we had expected to see compared to the whites. But what we did see for the South Asian men is when we followed them in 5 years, they actually had more rapid progression of how much atherosclerosis there was, even compared to the whites. They were just kind of, moving faster with the evolution of the atherosclerosis.
Did that correlate with symptoms?
No. Again, these people are asymptomatic, right? So they're in the study because we're trying to follow them over time. We've been following the original cohort now for almost 12 years. And we are expanding the cohort to include more people. And we want to follow people for, 20 years or so to really look at who develops heart disease, who develops stroke, and then what factors help us predict those who do. It's a natural history study in that way.
Yeah. So actually, the calcium is increasing in these arteries, but they're not necessarily developing symptoms from it.
Exactly. It's a marker that there is ongoing hardening of the arteries, and these are the people who are more likely to eventually develop heart disease and symptoms, right? When you have a lot of plaque,
Totally.
inevitably when plaque ruptures, that's kind of usually the causal pathway that leads to a heart attack.
Okay. And how about metabolic syndrome? Would you say that that's different in South Asians in terms of how it presents and maybe the criteria?
Yeah, so I mean, I don't think in terms of metabolic syndrome as being one entity. I think, metabolic syndrome really stems around having a clustering of many different metabolic risk factors. One set is high blood pressure, one set is lipids, and one set is glucose. And we've already talked about diabetes being highly prevalent, and so that glucose problem is there. But what about the problem with lipids? So it turns out that the lipids that you see in our study are slightly higher levels of triglycerides and slightly lower levels of HDL, the protective cholesterol, but not that outstandingly different from the other groups in MESA. So there are other lipid factors that aren't your standard cholesterol factors that are different, and that's LP little a, lipoprotein little a, is high in South Asians, but it's even higher among Blacks in MESA. So the average level in Blacks is 35, and in MASALA, the South Asians, it's 17, and in the other three groups in MESA is much lower than 17, 8, 9 in that range. So you can see South Asians do have a higher LP little a level, but not as high as Blacks. Okay, so that's
somehow it seems like Black people are protected relatively compared to South Asians.
I wouldn't say protected. I would say that the overall incidence of heart disease, when we look at big data coming out of Kaiser and other countries, show that South Asians have even higher rates of heart disease compared to Blacks, but Blacks do have quite high rates of heart disease, higher than whites and other groups. Yeah. So LP little a is one of those aberrant parts of the metabolic syndrome if you put it all together. And then the other piece was high blood pressure. Yes, South Asians do have high blood pressure, actually. Not the highest compared to all of the MESA groups, but second highest to African Americans. So the Blacks in MESA had the highest prevalence of hypertension, and South Asians were second again.
Oh, interesting.
So definitely all components of the metabolic syndrome are problematic for South Asians. And why is that? And so I think this comes to like one of our main findings is we did CT scans of the heart as well as of the abdomen in our participants. And we found that South Asians put fat in all of the wrong places. So although the overall body mass index, the BMI measure, may be in the normal range, and normal being, 25 to 30, that's the standard criteria, turns out that even if people are in the, normal being less than 25, overweight being 25 to 30. So even the people in the less than 25, or if you use the Asian criteria for normal, which is less than 23, we actually had a high proportion of people who had metabolic syndrome, even with normal, very low to normal BMI. And that was way more prevalent in South Asians than in any of the MESA groups. So the culprit, I think, that's kind of brewing with the metabolic syndrome is this problem of putting fat in places where it's not supposed to be. And I think one of those main problems is putting fat in the liver and putting fat around the abdominal organs, the visceral fat. So those two kind of go hand in hand and are probably, related to this problem of the metabolic syndrome.
Oh, that's so interesting. How much do you think of this risk do you think is genetic? I saw recently on your Twitter that you'd highlighted a recent study on the high risk of diabetes in South Asians in the UK being correlated to a higher genetic risk.
Yeah.
And what do you think?
Yeah, so I wish I had our data back yet. We're just about to do genome sequencing on our whole cohort this summer. Excited to partner with other researchers to do this work. So we don't have data directly from MASALA, but from everything that exists in other settings, I think the overall genetic risk, there isn't one smoking gun in terms of one, mutation. That if you put together several different, genomic variants together and create like a polygenic risk score, and there's one group at Harvard that has started to do that with UK data from the UK Biobank, is there is somewhat of a higher prevalence of this some genetic factors that seems to be one of the reasons. Now, how much can we quantify that? In general, that's hard to do without having a complete data set that includes genetics and all of these other risk factors we've been talking about, and that's what we're hoping to do in MASALA. But right now, my best guess would be that it's probably, explains maybe 15 to 20% of the overall risk. But the thing about it is, just because the genetic variants may be there or may be more common in South Asians doesn't predict the future. So other people have said this, and I haven't coined this term, but DNA is not destiny. And that's the bottom line, is even though there may be higher genetic risk, there is so much that can be done with behaviors and lifestyle and medications and treatments to prevent heart disease. So I don't get, I don't want people to get down on the fact that this is just inherited and,
Yeah,
doomed.
that's such a
I
positive.
don't believe in that. Yeah.
That's such a positive and strong message. I'm glad you said that and mentioned that. Okay. All right. How about would you say that South Asians have a unique physiology in any way?
Yeah, so I think this problem of putting fat in the wrong places is a somewhat unique physiology, but I don't think it's completely unique just to South Asians. I think several other Asian groups have the same problem. We've seen data from Filipinos and Japanese in the US, and they definitely also put fat in the visceral area as well as in the liver. And we've seen that strikingly, the groups that have lower levels of fat in the liver are African Americans, and Native Hawaiians seem to have lower levels of fat in the liver. So it's not uniform, and I don't think South Asians are totally unique. I think that there's a distribution of people who have this problem, and there very well will be a genetic underpinning to why this is happening. It hasn't been discovered yet, and I don't think, again, it's not going to be a one mutation issue. It's going to be these polygenic risk scores that help us understand who is at higher risk of putting fat in these organs where it shouldn't be.
Okay. Do you see any differences between men and women in your studies?
Oh yeah, no, big differences. We've actually found much higher prevalence of all of these metabolic risk factors in men than in women. Women are not risk-free for sure. Women do have, diabetes, high blood pressure, lipid abnormalities, and have been developing heart disease in our study as we follow them. But most of these risk factors I've mentioned seem to be even higher in the men, and that calcium in the heart is definitely higher in men than in women. When we compared our MASALA women to the women in the MESA study, the amount of calcium in the heart arteries was no different for the South Asian women compared to the whites, blacks, Latinas, and Chinese. So it was very similar across all of the groups. So, and why could this be? I think partially there may be a gender basis for this, that there may be some level of protection that women have, but I think a lot of this has to do with behaviors. So when we look at the diets people are eating, the women in our study are eating healthier diets compared to the men. Who's smoking? Women are not smoking very much at all in our study. Only 3% of our whole cohort were current smokers, which is very low compared to most parts of the world. And most of those were men. And so, there's differences in behaviors and lifestyle that maybe make the women in our study healthier than the men.
Okay, that's interesting. And what about, I've hearing a lot about polycystic ovarian syndrome in women, South Asian women in particular. Should South Asian women, have you noticed that? Should they be concerned about this?
Yeah, it's a great question. We have not explored that directly in MASALA. To be in MASALA, we took people who were between the ages of 40 and 84. So a majority of the women who came into MASALA are postmenopausal after the age of 50.
Okay.
So we only have about 150 or so who are in that premenopausal 40 to 50 or so years old. So we haven't been able to closely look at what the prevalence of polycystic ovarian syndrome is. It is a disorder that is highly linked to insulin resistance. And in my own clinical practice, the South Asian women I see, definitely there is a lot of polycystic ovarian syndrome, and that may be kind of what may be spurring women to go on and develop diabetes and metabolic syndrome abnormality.
Do you have any advice for South Asian women with PCOS or polycystic ovarian syndrome?
Yeah, no, absolutely. So there are many ways to manage and treat polycystic ovarian syndrome. Healthy lifestyle changes can really help in terms of the insulin resistance that women experience with PCOS, and healthy lifestyle changes can help delay or even decrease the onset of diabetes. So it's really important to work with your healthcare providers, your nursing and coaching staff to start walking and eating correctly, and trying to eat a healthy diet that optimizes your weight status so that you can have less insulin resistance. There are good treatments now as well for PCOS that include metformin and other ways to manage the other effects of PCOS on reproductive hormones, fertility, as well as weight gain.
Okay, great to hear that. What other risk factors would you say are prevalent among South Asians that maybe are somewhat unique or even not unique?
Yeah, well, I think the things that we found that could be sources of resilience in terms of what can we do, what's in our realm of control that could be very helpful. And what we found is the plant-based healthy kind of vegetables and plant-based foods can be very important. And in MASALA, we know that of the whole study population, we have 1,164 people in the study currently, and we're expanding the study to include more Pakistanis and Bangladeshi, so that we have three of the largest South Asian American groups represented. Currently, we have mostly 83% of our study is Asian Indian. But what we can tell from the people in the study already is 38% are vegetarian. But not all vegetarian diets are the same, right? It's a lot about the quality of the food. And what we found were that people who were eating a healthy plant-based diet, that with fruit, vegetables, nuts, and legumes, whole grains, they were less likely to develop diabetes when we followed them for 5 years. And the people who were eating more of the unhealthy plant-based foods, That's a lot of the starchy vegetables, rice, processed grains, sugar sweetened beverages, or other, sweets. They had, higher risk, and they had more of the fatty liver problem as well. So, I think diet is a very modifiable risk factor. So I really like to, think about that being something that we can control and what we can do. So it's about adding in, healthy plant-based foods into our regular diet. And that doesn't mean to completely move away from our cultural, traditions and the way that South Asians like to eat. It's about, adding or substituting some ingredients and keeping the flavor and the whole other aspect of that food the same. So diet is one of the most important, I think, control variables that we have. Yeah.
Okay. Do you have any specific like diet recommendations in terms of replacing or adding to the South Asian diet?
Yeah, so I mean, again, the healthy plant-based diet is what I would say is so really increasing the number of fresh fruits and vegetables. So I think one of the things in the South Asian diet, being Indian myself, is we do eat a lot of vegetables in our diet. And in fact, when we looked at the number of vegetables that our participants consumed on average per day, it was about 4 fruits or vegetables a day. And if we compare that right now to a study that's ongoing in India and in Pakistan, the average number of fruits and vegetables consumed by people living there now is about 2.3. So we know that the South Asians in the US are actually eating somewhat more fresh fruits and vegetables, but not all of that is fresh vegetables. We know that, the way the South Asian cuisines, a lot of the vegetables we eat are, cooked down and can be put into rich sauces and curries, and that can take away some of the positive, nutrient value and add more saturated fat and other problems with, deep frying. So it's about the quality of the diet. So I'd say, improving the healthy plant-based foods and trying to not overcook the vegetables that we're eating.
Okay, that's a really strong point there. Okay. What can South Asians do? Okay, sorry. What if someone has diabetes? What can they do to manage or possibly reverse? Is it possible to reverse diabetes once you have it?
Yes, absolutely. I think lifestyle behaviors, what we've been talking about with, healthy plant-based foods, trying to minimize red meat products because they have been associated with, worsening disease, not only diabetes complications, but heart disease complications. It's really important to start exercising if you're not already exercising. And that's because exercise, any kind of exercise, walking, can help to sensitize the tissues, the muscles, to understanding or being able to process sugar and be less insulin resistant. So really, the mantra is, walking 30 minutes a day, 5 days a week to prevent diabetes, or once you have diabetes, is continuing that level of exercise. I also like to say that I think there's a huge benefit in doing resistance exercises, not only walking and aerobic exercises. And by resistance, I mean by, any kind of weight using exercise, because that helps build the muscle mass. And that's what we found in MASALA, is not only do we put fat in the wrong places, but the amount of muscle mass in the average, South Asian body is much lower than in other groups. And so we need to, really consider, as we age, we preserve or gain muscle mass and reduce the fat mass.
Yeah, well, those are also great points. And how about, what can South Asians do to prevent heart attacks and strokes? Are there some uniquely different things in addition to diabetes?
Yeah, no, I think
specifically for heart attacks and strokes?
Right. I think overall we found that a lot of the same risk factors that operate for many different groups operate for South Asians. So that means, smoking, quit smoking, get your blood pressure under good control, optimal being 120 over 80, get your blood sugars down into a normal range. If you have diabetes, really work on your healthy lifestyle and get on medications. And we have some really great medications now that can help prevent the risk of heart attack in those with diabetes. And then the lipids, controlling cholesterol levels if they're high. And also, I think it's really important if you have high Lp(a) to be mindful of that there is an additional risk factor that you have. And unfortunately, there's no great medication that targets Lp(a) yet. There's several in the pipeline, and I think in the next decade we'll have some real, therapies that will be able to reduce Lp(a) levels. But statins currently don't reduce Lp(a) levels, and nothing else really does a great job. But we do know that healthy plant-based diets can have an influence on Lp(a) levels. Really getting them as low as possible with what you eat is important. And so, and then knowing your numbers, knowing where you are, and kind of working with your healthcare providers to manage your risk factors. And I think another thing that we haven't talked about yet is stress. And we found in MASALA that, men who reported higher levels of depression had more thickening of their arteries in their neck. And women who reported higher levels of stress had thickening of the arteries, and this is related to having higher risk of stroke. And that was after we controlled for all other risk factors, everything we've been talking about, lipids and smoking and diabetes and high blood pressure. And so there is this effect of stress on our heart and on our blood vessels that we don't really understand. But part of it could be that when we're under a lot of stress or emotional distress or mental health issues, that we're not taking as good care of ourselves in terms of the exercise we do or the diet we eat, or smoking more or drinking more, things that may have adverse effects on our diet.
Yeah, I heard there was a recent study that talked about how stress can actually negate the effects of a good diet.
Absolutely.
Yeah.
Absolutely.
All right. And how about, can you explain, one of the findings in the study was that there was higher risks of cardiovascular disease in people who are of Pakistani or Bangladeshi origin compared to people who are of Indian origin.
We haven't had enough people in the study to make that a definitive statement, but certainly a recent study that came out of the UK Biobank looked at this because they had about 5,000 South Asians. Majority were Asian Indian, but they had Pakistanis and Bangladeshis in that study as well. And they looked at what happened in 10 years when they followed this group, and they found that the Bangladeshis had the highest risk of having heart attacks. The Pakistanis were second, the Indians were third, but all three groups together were way higher than the European women in the study. So all three South Asian groups had high risk, but there's kind of differences among the subgroups. And that's what spurred our interest in adding more Bangladeshis and Pakistanis into our study. Is not only has that been seen in the UK, but also in Spain and in South Asia. We've seen this coming, the data coming out of Pakistan, that there is a higher rate of.
How much higher was it, by the way? Just curious.
Yeah, so I mean, these are in odds ratios or in relative risks, and so it was considerably higher. It was almost threefold higher risk in Bangladeshi, 2.5-fold in Pakistani, and around twofold in Indians, but much higher than compared to the whites. Right?
That's pretty remarkable.
Yeah.
Can you talk about the role of restorative yoga in mediating blood pressure and waist circumference and your PRISM study, PRYSMS study?
Yeah, no, we did that about a decade ago, and that wasn't focused on South Asians only. We actually included anybody. We had a nice group of white, Black, Latino, and Asian Americans who took part in the study. It was a 1-year-long intervention. One group got restorative yoga, and one group got active stretching exercises. So they met in groups. They also practiced at home. We really followed them very closely to see how much they were practicing. We put them, through the classes where they learned how to do the restorative poses correctly. We gave them props. And what we found.
By the way, can you just define restorative yoga just for our audience?
Yeah, restorative yoga is very different from what you think of when you think about yoga. It's not exercise based. It's not active poses or asanas. It's actually restorative or relaxation poses. So
Okay.
think of legs up the wall with the eyes closed. That's a classic restorative pose. Think of Shavasana. That's the final resting pose, the corpse pose. That's a restorative pose. Because the point with doing restorative poses is it helps to relax you, it helps decrease stress levels, it helps to improve sleep. So it's a type of yoga that's accessible to anybody of any body type, of any ability, because it doesn't require getting into these very difficult poses. And so the average weight of the people in the study, the average BMI was 31, quite obese in the study. So we really wanted to find ways that an obese, sedentary population could
be able to participate. Yeah.
Yeah, and what we found was that the people in the restorative group had lower fasting glucose levels after a year. They dropped their glucose. They were all pre-diabetic, the people in the study, 180 people or so who we followed for a year. And the people who were in the restorative yoga group dropped their glucose levels by 6 milligrams per deciliter. And that's remarkable, to start from 110 to go to 104. And that's with just the restorative yoga. Both the groups were eating the same kind of diet. Both of the groups were doing other physical activity exercises about the same through the study. There was no difference there. So we don't think that they were exercising more as a result of doing the yoga. Yeah.
And did you say they also dropped their waist circumference as well?
They did. They did have a change in waist circumference and in the visceral fat and the subcutaneous fat. And that we did CT scans in that group. So it's really a nice, less well-known type of intervention that people could do. And again, back to that, we were talking about stress and how that's maybe an independent risk factor that we don't really measure well clinically when we see patients. How much stress do you have? But doing things for ourselves in our own lifestyles to help reduce the stress that we have, I think, is really important.
And you think restorative yoga may actually be reducing stress in people, and that may be part of the mechanism that it's.
I think so. I think it's very difficult to measure, and that's something that we weren't able to show definitively by measuring levels of stress hormones. But I think that is one of the key ways to reduce overall levels of activation and relax.
Okay. And what can be done to improve awareness for South Asians of this situation? I think a lot of it, the issue is that people are just not aware that this is going on. And then would you define it as or would you call it an epidemic or a crisis or a healthcare crisis or a health crisis?
Yeah, I think that the prevalence of early heart disease is growing, especially in South Asia. And so it meets epidemic criteria for areas of South Asia. In terms of being, an epidemic in all parts of the world, I'm not quite sure if it is. I definitely think that we need to raise awareness in South Asian communities, and that's by spreading the word through social media, through talking to friends and family, for other parts of our South Asian sectors to get involved, like, the markets, the restaurants, the entertainment industry, for, anyone who is working with South Asians to, use their voices, use their platforms to engage people, to get people to start making small changes, getting more active, eating more healthy plant-based diets. These things are, difficult to do, but I think having more people adopt this and starting doing it early in life, and that's what we noticed with our data in MASALA. The average age is 58 in MASALA, and when we talked to the people about what were the most important influencers in their life, who would help them make healthy lifestyle changes, it's their adult children. So for second generation South Asians growing up in the US or UK or other parts of the diaspora, you have an unbelievable influence on your parents and on your relatives and on your community, because having them hear that what you're doing, if you're exercising more, eating healthier, will be influential for your parents if they're not exercising because they didn't grow up exercising. But seeing you exercise can help them to move, and that's what we did find in our study.
That's really neat. And when thinking about your research in this area, what do you say is your overall goal and or mission?
Yeah, no, I think our overall long-term study goal is to really understand why there is so much more heart disease. What are the factors? And to
Hmm.
be able to say that, like you said, there are no good clinical risk prediction tools for South Asians. A lot
Mm.
of South Asians come to me and they say, look at this risk calculator. This is the standard risk calculators we use. In the US, UK has slightly different versions of those risk calculators that include the
Yeah.
little South Asian component. None of them are good. None of them are accurate. It turns out that they're both lousy. And so what can we do to improve the prediction of people so that people
Mm.
aren't blindsided? First of all, we raise the awareness
Yep.
and we help them, know their risk so that people can start getting engaged and active and prevent heart disease. I'm a primary care doctor. I see patients. My whole realm is about prevention rather than, treatments. I want to get earlier upstream and try to prevent the problems before they happen.
Okay. Um, I was going to ask you earlier, you alluded to some good things that are found in South Asians. Can you mention some of those?
Right. So I did mention that that there's a lot of vegetarianism, and so there are people in the study who are eating, a healthy plant-based diet who are preventing the onset of diabetes. So that's definitely something there. Other sources of resilience is the social networks that South Asians have. They're actually quite rich in the number of South Asians and how many family members are in their social network. So we mapped everybody's social network in the study and found that people who are in the study who have very rich, dense social networks have a lot less stress in their
Uh,
life. It turns out that the most influential people in their life to help them, like I said, was their adult children. In terms of walking, to the people, men who walked with other friends were
mhm.
walking for more minutes per week, and
Oh,
women
wow.
who walked with their spouses walked for more minutes per week. So walking with people who are close to you really does help people get more engaged in activity. So those are some of the resilient factors. We also found that that religion and belonging to spiritual organizations is a source of resilience and support for people,
Okay.
and people who were more active with whatever religious organization or activities actually had better quality of life overall.
Hmm. Um, do you have any interesting new findings or research that we should be aware of?
Yeah, we
Besides
are.
what we've mentioned?
Yeah, well, there's a lot of things going on with MASALA right now. We're going in like 4 different directions. As I mentioned, we're starting the genetic analysis now. We are also going to be measuring environmental toxins that we've been exposed to
Oh,
in the blood stream. So we just got a new grant to do that, and
wow.
that's quite exciting because in some preliminary data we've shown that South Asians tend to have higher levels of certain chemicals that are found in pesticides
Oh,
in
interesting.
their body, and we tend not to we can't metabolize these levels of chemicals, and these chemicals can cause some effects on the fat in the liver as well as on diabetes risk. So we're measuring those chemical compounds in the blood of the
Oh, that's so
participants.
fascinating. So you're actually saying that we may have trouble metabolizing pesticides compared to other ethnicities.
Yeah, no, I think we're just more exposed. So it's not that
Oh,
we're metabolizing any differently. So DDT is the pesticide. So we've published one paper from our pilot study about DDT. So DDT, once you're exposed to DDT, it's a pesticide that's no longer used in the US or most parts of the world.
okay.
It's still being used in India and Bangladesh for mosquito
Oh, okay.
abatement. And turns out that once you're exposed to DDT, because you eat the food that is grown in the area that was sprayed by
Hmm.
DDT, it never leaves your body. It stays in the fat cells. so we can measure it. And so when we looked at the levels of DDT in our participants, it was quite a bit higher than average levels in the US,
Oh, wow.
significantly higher. And we correlated that to the risk of diabetes and fatty liver.
Oh, wow.
So could that be a potential toxin that is causing us to develop more diabetes? And that's certainly something that could have big public health consequences. And, we need to be more aware of that because most countries have banned DDT. India was supposed to ban it, but I think that that deadline has been delayed for when they're banning DDT. So I'm not quite sure if it's currently banned or not, but it was something that was in process of happening.
Right, totally. Oh, that's interesting.
And the other big things that we're doing right now is we're expanding the study, as I said, with Pakistanis and Bangladeshis. We have a small pilot study that's happening in Chicago where we're recruiting the second generation, the adult children of the people in our study, to look at how they're doing, how their risk factors are compared to their parents and compared to other second generation immigrants in the US.
Oh, amazing.
Yeah.
Well, that's great. I applaud you and all of your diverse areas of research regarding South Asians. That's
Thanks.
really wonderful.
It's a pleasure and a privilege, and I really want to thank our entire team that's at UCSF and at Northwestern University. My co-PI there is Dr. Nami Kandula. We have a new team that joined us for our expansion now at New York University, Dr. Nadia Islam. And we have collaborators all over the US as well as in India and Pakistan. So I really want to thank people who contributed to what we've learned.
Do you have any concluding message to the South Asian community in terms of what they can do or a general statement?
Yeah, I mean, I'm really optimistic. I think that, that we are finding that many and most of the risk factors for developing heart disease and diabetes are in our control, that we have lifestyle behavior changes we can make. There's a whole realm of social determinants that we didn't talk about, but those are, things that we can try to modify and improve structurally as well as, socially. And so, I feel like, again, if there is a genetic underpinning to why there is this problem in South Asians, I'm still optimistic that there's a lot we can do to prevent these diseases.
Well, great. Well, thank you. I guess we'll conclude our program then. And Dr. Kanaya, really appreciate your time and of course your passion and energy in this. And we will conclude our program, Expert Spotlight. We just interviewed Dr. Alka Kanaya, who is the principal investigator of the MASALA study, and she's a leading, of course, medical researcher for South Asian health. And this program, of course, is for South Asian Heritage Month, and we are very pleased to have had her for this interview.
Thank you, Mubin. Thank you. Thanks for having me.
Yep, thank you. And this is your Desidoc, and please continue to follow. Thanks. Bye.